We have 5 minutes. Anybody wants to use the? Oh, did you have a question?
No, I was just going to say this created quite a bit of controversy at Tumor Board because the medical oncologist was adamant that we had to take the primary out. Whereas my thought was, if we're learning from watching and waiting, I don't understand where that fits in if we're at a near complete response. And I think it's underappreciated how if you operate on someone and they've had an excellent response overall, that all of a sudden you induce this inciting event. I mean, how many times do we see metastatic disease pop up 6 to 9 months, and it's not going to be the local part that ultimately, unfortunately, anyways.
I mean, we've seen a lot of evidence nowadays on even looking at microbiome. As you probably saw from recent publications, looking at the microbiome to predict cancer recurrence. Right? Ben and Cyrus are leading nationally in this. So this is something that we may incorporate in surveillance programs in these patients. All right. Yep. Get a cup of coffee. Go to the bathroom if you need to. We'll start in 2 minutes.
Kate, I do this radiation, finish it out, and then.
I'm sure I have a policy. You can't do that.
I am gonna
You went to a I feel like certain cancers where you're going to get strict. They were like,
You've been in a car accident.
That's the state. In this case, she's not diverted.
Why would I go to Kitty?
It's massive. It's massive.
It's early rectal cancer. This keeps on evolving.
It's going to
Good thing that not too much patients.
Like, no, that's
Like,
Sorry, I was missing something. You heard about it? I
I'm sorry, you okay? Driving or
No, I was
you were behind the wheel? Car accident already? Who'd you hit?
So there was practice with bicycles.
I want to ask about there's like what went wrong.
So, didn't see.
Glad you're okay.
Yeah, that's a year or two ago, you couldn't even drive.
That is so. No, Hennepin.
I know, I'm just joking.
Sarcasm.
I would die here.
Get there like 20 minutes late. Yeah, that's fine. As long as you're okay, that's fine enough. Just remember, just drive the speed limit. Not too slow, just drive the speed limit. I failed my first test. Second person was Nigerian, so I thought.
Hey, that's.
He knew my dad. He knew my dad. Fine.
Get me to August.
You want to go to California? Yeah.
I did a lot of
Exactly. It's not like just get wet. Brett feels beyond it. He's tired.
It was coming soon, right?
Yeah, there's a big data say no, they put me for like 5, 6 minutes.
You enjoyed dinner last night? You enjoyed the talk last night?
Watch you staring at me, my mom.
Yeah, absolutely, yeah.
Cooking? Right.
Yeah, she's cooking, yeah.
What's it good?
That's the mom that you can see. I can't wait to not cook it and
Is your mom cooking?
yeah.
He's probably rating it once.
And I would make the case, I would really.
I would redo
If people want to take their seats, we'll get started here.
It was a good time.
no matter where you are, there's ladies back. And my side. Yeah, okay.
Hi, I think we're ready to get started if you come and have a seat.
Maybe. I look like a worker in scrubs.
I'm doing the general.
All right. I want to welcome our M-Step behind us. These are mainly undergrads, right, from all over the country, and that are interested in biomedical sciences. So welcome to the Department of Surgery. All of us are pretty easy on coming into the operating room whenever you'd like, approaching us in the hallway, talking about research projects, of how you could help with that, how we can help you with publications and stuff like that. So welcome. Every year we distinguish one of our colon and rectal surgery alumni. And this year, 2026, the alumni we're distinguishing is Charles Oswald Finney III. Oz is a native of Virginia. He did his BA, his bachelor's at Vanderbilt. He went to medical school at the University of Virginia. He did his residency at Brooke Army Medical Center in San Antonio, Texas. He's an alumni from 1981 of the University of Minnesota Fellowship. He spent, was it 2 years in Germany, Oz, after that? 2 years in Landstuhl, after that. And he joined our faculty in 1983. And he was on staff until 2015. Dr. Finney was a pioneer in endoanal and endorectal ultrasound. Single-handedly, he probably had one of the largest TEM series in the country. Also with endocavitary radiation that we talked about yesterday, that's coming back. He taught me everything I know about pilonidal disease and perianal dermatology, to the point where ASCRS asked me to write the book chapter, which I was scared about. I was scared of writing. What I think has translated a lot from us is that, do you still have your Excel sheet of all the data from every single patient you did a TEM on?
Well, it's in a program that is minimally supported. I still have it, but my current version won't open.
So that really translated with, I think, a lot of the fellows. Dr. Finney would sit down after every case and would have every single measurement, duration of the case, EBL. After every case, he would sit down and he would input every data point. And when the fellows would come and we wanted to do a TM paper, it was like already done, right? The data set was already there. So that, when I started robotics, I did the same exact, I don't do it anymore, but I did it for about 7 years, I think, about sitting down after every case and putting in every little detail about it. And unfortunately, data sets nowadays, there's a lot of flaws in everything. There's a lot of surrogate information. But having a surgeon document the details of every case, that stuck with a lot of us for a long time. Dr. Finney was just an unparalleled, the dedication he had to his patients was just unparalleled. So congratulations and thank you for being here today. And to honor, yes. When we honor one of our alumni, we ask them, who would you like for us to come and give a talk? And it immediately was Julio. Dr. Julio Garcia-Aguilar is a native of Escalona, which is just outside of Toledo, which is near Madrid. Highly recommend it. He went to medical school in Madrid. He did a full 5-year surgical residency, came to the United States and redid his entire surgery residency and research fellowship at BID in Boston. He is a alumni of our fellowship from 1993. He went back to Madrid from 93 to 96. Dave Rothenberger, Stan Goldberg, and Rob Madoff recruited him back to the University of Minnesota from 1996 until 2002. And really, Julio has never really left the University of Minnesota, even though he's been all over the place. He went to UCSF, and he's been a chief of colorectal surgery or surgical oncology at all these institutions. UCSF, City of Hope, MSK. Currently, he's the chief and Benno Schmidt chair in surgical oncology. There's really not much you can say about Julio's path in research and publications and how he's been a trailblazer in the management of colorectal cancer, specifically rectal cancer. It's just changed every year. You can see, I don't think I've given a talk on rectal cancer without citing one of Julio's papers, ever. He's just had such an impact on how we do it, and he's like the nicest person. You approach him and you ask him for advice, and he's always with a smile. He's always willing to talk to you at meetings. So today we are honored to have him here honoring Dr. Finney. Welcome, Julio Garcia-Aguilar.
Well, thank you for your kind words, both, and thank you also for, thinking about me to come here. It's a real treat to be here at the University of Minnesota, because even though I train in general surgery in other places, everything that I have done in my career, particularly related to rectal cancer, come from the work that I started to do here and for the work of the entire group in the colorectal group here at the University of Minnesota. I remember being here in Grand Rounds in this conference room many times and over the years, so it's a real treat to be here today. I'm going to talk a little bit about some of the work that we have done over the years in rectal cancer. These are my disclosures. They are not very pertinent to what I'm going to talk about today, because it's going to be mostly about not doing surgery for rectal cancer. I came to the United States in 1985, and I follow the literature and how the treatment of rectal cancer has evolved. From all these trials of using radiation therapy and chemotherapy. But when I came to the University of Minnesota in 1992, 1993, we were ahead of the curve. In many places, they were doing surgery, in some cases, postoperative radiation. But here, because of the legacy of those previous trials, we were doing chemoradiation already, TME, and then giving postoperative chemotherapy. We were, again, quite ahead of the curve. So I was able to observe early on the effect that chemotherapy radiation had in the rectal tumors. So that kind of is what started my career, just being able to observe the response of chemoradiation in rectal cancer that many other people didn't have. So that treatment strategy worked very well. We have a very low rate of local recurrence, which was the goal of the radiation. We have a very decent survival, but still there were problems with this treatment. The treatment was very harsh, had a lot of impact in the quality of life of the patient, and then we had to deal with the issue of the distant metastasis. Part of the reason why we had some problem with the metastasis was the whole issue of giving chemotherapy after having given the patient chemoradiation and put them through a major operation. Not many patients tolerated the chemotherapy well. So, they were the challenges that we faced when I started my practice here in Minnesota in the 1990s to, improve survival by reducing distant metastasis and also improving the quality of life. And at the time, the issue of the response to the primary tumor was what led to my career, essentially trying to optimize the use of neoadjuvant therapy to make the tumor go away and avoid surgery, which was a significant cause of morbidity. Now, of the three components of the radiation, the surgery, and the chemotherapy, the radiation really was pretty well studied, the randomized trial that improved, that they were able to reduce the risk of local recovery. That was kind of pretty well accepted. TME surgery, of course, has taken, has been tested with time, were very effective. The main issue was chemotherapy. Why it was not working? In the United States, we believe in chemotherapy, we get chemotherapy. In Europe, they were a little bit skeptical about it. So you do radiation and you do TME, do you really need chemo? It's been proven that chemotherapy works and doesn't work. And this is data from a pool analysis at the patient level of 4 clinical trials done in Europe that the Dutch conducted, suggesting that was not that much proof that chemotherapy was effective. Now, here in the United States, we say, well, it's not effective because you have low compliance. Not many patients get the chemotherapy after chemoradiation and surgery. They are exhausted, they have palpitation, they have the stomach, they just don't want it. And also because the regimens in those trials that they did in Europe, they were outdated. So in the United States, we believe in chemotherapy. And the issue was, okay, chemotherapy, we believe that it works and we have problems with compliance after surgery. Why don't we move it to before the surgery and see if that way we can improve survival? And that's what people started to do in different ways. Medical oncologists started with the chemotherapy, then the radiation, and then the surgery. This is what they started doing at MSK a number of years ago. And this is a retrospective analysis of our patients that Andreas Sersek published a number of years ago. And what this data showed was that response increased when you move the chemotherapy up front, then chemoradiation, and then surgery. Of course, there was a long treatment from the beginning of the chemo and the time that you did the surgery, but survival was exactly the same. There have been prospective trials addressing the TNT. This was a small trial in Spain. They compared chemoradiation, surgery, and chemotherapy with chemotherapy, chemoradiation, and then surgery at the end. And then they showed, again, no difference in survival. More response, but no difference in survival. Another trial here in the United States with a very different design, but eventually what they were doing was comparing the standard treatment with the induction chemotherapy, chemoradiation, and surgery. A lot of interest in the United States, but again, no difference in survival. So kind of it was a little bit of a questionable whether TNT was going to be effective or not. The idea of giving the chemotherapy before chemoradiation and surgery. This is probably the trial that you have heard the most about this thing. It's a French trial that they started with chemotherapy, then chemoradiation, then surgery, then more chemo versus the standard treatment, increasing the rate of response, an apparent increase in the disease, better disease-free survival, but no significant change in overall survival. And this trial has been very controversial because, they claim, well, there are less metastases, there is borderline intolerance. The problem is that this seems to happen very early on, even before the patient has surgery. So it's very difficult to really see what we are measuring them. Events in patients, DFS events are usually radiological events, and we don't know how real they are and what the impact is of those radiological events on survival. We have to keep that in mind. The endpoints are very different. At the end of the day, the important endpoint in surgery is overall survival, whether at the end of the day you are alive or dead, because just saying that you have some image in a long CT scan or, the liver is irrelevant. The thing that in this study, what explains the difference in survival very early on is that there were significant more cases that they die in the standard arm than in the experimental arm. Pretty difficult to explain why more patients will die when you start with radiation compared to the patient with chemotherapy. So I still take this data with a grain of salt. Cancer-specific survival were no different between arms, which is a little bit more of a better endpoint for this trial. Now, of course, the more chemo that you give to the patient, the more toxicity that you get. I think that goes without saying, particularly when you use a lot of oxaliplatin. Neurological toxicity is a major issue. When you go beyond 4 months of oxaliplatin, you start seeing significant neurotoxicity. Now, the other approach to what we call TNT, and we stumbled into this, this trial came from Minnesota. We started this work here. Was the idea of, okay, why don't we do the radiation and then we do the chemotherapy afterwards and we see what it will happen if we delay the time of the surgery. And it was a series of sequential phase 2 trials. And what we were able to prove was by delaying the time of the surgery and give chemotherapy while we waited, so doing consolidation chemotherapy, the pathological complete response rate went way up. In my case, I was not looking for differences in survival. I was looking for differences in response because I was pursuing the idea of organ preservation. So this was the trial that we did prior to address the issue of avoiding the surgery. The idea of avoiding the surgery in the 1990s was still taboo in this country. Nobody will agree to that. They will tell you that you were crazy. So we have to do this intermediate study. The response rate was going to be high enough that you're going to be more attempting organ preservation. So that was the justification of this trial. That again, as I say, came from my days when I was here in Minnesota. I wrote the trial. It took a while to get it approved and funded by the NCI before we were able to do it, but at the end we did it and did what it showed. There have been other attempts to do a similar approach of using radiation and then chemotherapy and then surgery at the end, and this is the Rapido trial. instead of using chemoradiation, they used short-course radiation, but the idea was the same, short-course radiation, chemotherapy, surgery at the end. Also, they showed that there was increasing response rate, but no difference in survival. So there have been other couple of studies similar to the Rapido trial, smaller, that they have shown similar results. Again, the difference in DFS happens very early on. I think it has to do with the time when you do the imaging studies. In one group, you do the imaging studies at one point. In the other group, because of the difference in treatment, you do it at a different point. So what the X-rays show might be different, but those differences, they seem to have very little impact on survival. In this case, it's the issue of survival after metastasis. In the Rapido trial, in the control arm, only half of the patient got any chemo, and still they did better. And there is this potential issue of the survival after metastasis when you have received chemotherapy upfront versus not. And this is a kind of a debatable biological potential issues that might happen with chemotherapy, before the patient develops metastasis. Of course, similar to this 23, more toxicity when you do more chemotherapy. I think that goes without saying that. So what have we learned from TNT? What we learned from TNT is that increased response. The improvement in survival is not there, in my opinion. It hasn't been improving. Of course, there is more toxicity. So is TNT effective? Well, if you don't change your treatment plan, it's probably not. If you're going to take everyone to the operating room, it's not. So kind of this validated the hypothesis that we have, that we wanted to do TNT to increase response and then being able to change the treatment plan for the patient. And then is where the issue of avoiding surgery comes from. This is not a new idea. At MSK, they were doing radiation therapy and watch and wait 100 years ago. The problem was that the radiation were not very effective, the way to select patients were very bad, and the reason why they wanted to do organ preservation in those days is because the mortality from an APR was tremendous. Surgery became more effective, safer, and patients did better with surgery alone, the pendulum moved. They started to use radiation as neoadjuvant. But it's a long story with that. It was not something that we invented. It had been around for a while. I think this is an important slide. This is Angelita Abragama, was the first to really kind of publish in this area. Here at MSK, I remember cases by Rick Niemer and other of my partners that they did the radiation and chemotherapy, the tumor went away and they didn't operate on them. But we never published on that. We never popularized it because it was seen kind of really out of mainstream. Angelita, who passed away on Saturday, by the way, it's sad to hear, but she passed away on Saturday at the age of 95. She had the guts in the late 1990s to come to CLS and say, well, patients that they have a response, we don't operate on them. She was run out of the podium. I mean, she was giving hell, but she was right. So that what inspired us to do the work. And what she showed is that patient who had a pathological complete response did the same as patients that they had a complete response and they were observed. So he said, well, the referral of surgery in patients with a clinical complete response is safe. If the tumor come back, some cases they are going to come back, then you can do surgery there, and that seems to be effective. And long-term survival is the same for a clinical complete response as it is for a pathological complete response. I mean, it was a retrospective case series with all selection that you want, but this paper from 2004, it was a big deal in terms of the organ preservation. At that time, we were already doing the timing trial. Then there have been publications of pool analysis of patients from many different sites that they put all them together. This is just patients who got clinical complete response and they put together in a pool analysis led by Rodrigo and Gerard Bies in the Netherlands. And they show the same thing that Angelita showed. When you do a watch and wait for a patient with a clinical complete response, some cases are going to come back in the first couple of years. I mean, you can see in the curves in here, some of them they will come back, but you can salvage them. At the end of the day, the survival seems to be the same, that you have with these people. The problem was that, the denominator was unknown because they were only patients with complete response. There were no uniform criteria for inclusion. What patient do you put in watch and wait? We don't know. There was a variable treatment regimens. There were no information about the timing of assessing the response. There were not even criteria that they were well defined. So there were a number of things that they were common to a retrospective series. So that's the reason why we eventually, after having done the timing trial and increased the rate of response to almost 40%, we decided to do this thing. We're going to do now total neoadjuvant therapy we are going to wait, we're going to restage the tumor after, for 8 to 12 weeks. And then the patient who had a complete response or near complete response, we're going to wait and watch them. The one that they have incomplete response, they need to go to the OR. We introduced the idea of near complete response because we knew that response takes time. And by waiting in patients that they have a little bit of a superficial ulceration or some nodules, we wanted to maximize the opportunity for response. And that has been very controversial, but I think that we were right on target. This was a phase 2 trial randomized to chemotherapy first or radiation first because there was a lot of debate at MSK. I came to MSK with radiation first approach from the timing trial. People at MSK were with the chemotherapy first. So in order to compromise and be able to do the study, we had to get a randomization, which, by the way, also the NCI supported better than a single arm. But it was a phase 2, and the comparison was historical controls. We say that treatment approach that includes watch and wait will result in 50% or 40% response rate. In fact, we hypothesized less than that. We thought they were going to be like 30%. And the survival should be the same. So the watch and wait will not penalize survival in patients with rectal cancer compared to historical controls. That was not what we say. What we say is that the TNT were going to be better because at the time we didn't know whether it was better or not. And that was the way the trial was powered for sample size calculation. Of course, we had to show the criteria for response because in a multi-institutional trial, you have to make sure that everyone is talking about the same thing. If we talk about complete response, both clinical, endoscopically, and radiologically, or incomplete response, we're going to be talking about the same. And again, we introduced this middle group. That's what we talk about near complete response. The tumor is not completely gone. The scar is not perfect. There is a small ulceration. We say, well, we want to give those cases a little bit more time to see if they respond. And I think that's important to understand watch and wait today. We follow the patient like we did here with the local excision. We see them every 3 months. We do endoscopy, we do MRI, CT scans every year, colonoscopy. Just have to keep the patient watching them regularly if you're going to do watch and wait. These are the patients in the trial. To emphasize that they were most of them not positive, very distant tumor, because those are the ones that benefit from watch and wait. We didn't consider this necessary for open rectal cancer. And, most of them, they were T3 or T4s. There were a few not positives that they were T2. And this is what happened. When we finished the treatment and we did the restaging, 3/4 of the patient went into watch and wait. Some of them developed regrowth, more in the patients treated with chemotherapy first than the patient with radiation first. And we still don't have an explanation, and there's a lot of debate about that, why starting with chemotherapy leads to a more tumor regrowth, but it still is a little bit unknown. So at the end of the day, we developed this new kind of outcome, which is TME-free survival. Patients who are alive and they didn't require TME. And what we show here is that when patients get radiation and then chemotherapy, more than half of them, they keep the rectum long term. The proportion is a little bit lower, around 40% for the one that get chemo first. So that was the first lesson that we learned. Of course, that was the clinical response, but there were some pathological responses. We did some local excision that there was a protocol violation because the study mandate to have all of them TME, but you have to accept some protocol violation. There was still 9% of PCR. If you put the PCR in top of the CCRs, you get close to 70%. So rectal cancer is very responsive. R0 resection for patients who require surgery, which was a minority, was still very good. Now, we have since then looked at predictors. Patient with lymph nodes, less likely to respond. Patient with EMBI, less likely to respond. Tumor big that they reach the circumferential resection margin, they are also less likely to respond. And the tumor size. So bigger tumor, more advanced, less likely to respond, but still some of them respond. So we are not changing. I mean, you have to be aware that if a tumor has those characteristics, you're going to be less likely to respond, but there's some of them will. Now, disease-free survival. The disease-free survival at 3 years, which was the endpoint of the study, was 76%. And it was the same for both arms, whether you give chemo first or radiation first. Now, the study was powered for 85% disease-free survival. We expected that TNT were going to improve regarding to our baseline of 75%, but it didn't. So that was a surprise. And 76% seems to be a number that appears in many other rectal cancer trials where they have done TME. So it sounds like we have there a 25% probably risk of, metastasis that we are kind of stuck. When we look at the results, chemotherapy first, radiation first, this is one of the things that is misunderstood by the medical oncology. So this is a very aggressive tumor. We have to give chemo first because the survival is going to be better. Wrong. It's the same. Whether you do chemotherapy first or radiation first, it doesn't really matter. I think we have this debate every day with the medical oncologists. It doesn't matter for local recurrence, for distant metastasis, or overall survival. Now, the problem of watch and wait is the issue of tumor regrowth. We put the patient in watch and wait, and we know that there is 25, 30%, depends on your criteria for selection, that the tumor is going to come back. So what happened with those cases? Well, this is a typical case. This is a patient of mine, a baseline. You can radiation, the tumor goes away, the tumor seems to be gone, and then something happened. Then we take a biopsy, says high-grade dysplasia. When you have a response and the tumor come back, it's very difficult to tell how deep that tumor is or not, because they tell you that the cancer cells, they are all gone, and we have been very aggressive in salvage this patient. You can see the size of the lesion. This is not the original tumor. So we did an APR and the patient has a white PT2. Patient did fine and is alive. But the regrowth is the biggest concern about watch and wait, and depends on the tumor characteristics that we have seen, and also the criteria that you use for response. If you use very stringent criteria, the rate is going to be low. If you are more relaxed and you include the near complete responses, it's going to be much higher. Most of them occur very early on, most of them in 2 years. I have seen one case with regrowth 9 years, but it has been only one case in probably more than 1,000 that we have now that has had a regrowth beyond 3 years. But it can happen. So that's one of the concerns that I have with watch and wait long term. And most of them, they are visible with endoscopy. That indicates that the endoscopy is the most important test in following the patient with rectal cancer. MRI is important, but endoscopy is by far the most important one. So the risk, and there is a lot of debate with Rodrigo and other people about what this means with the regrowth. The fears are that if the tumor regrowth is going to be uncontrollable and you are not going to lose the patient. That happens very, very rarely based on our experience. If you follow the patient closely, you have to have a compliant patient, the risk of regrowth is very low. And then the other debate is, what happened? I mean, patients, with the regrowth, they tend to have a higher rate of distant metastases compared to the response. And the response is, well, yes, I mean, the tumor doesn't go away. So there is a higher rate of metastasis. But is there metastasis coming from the regrowth, or is something that was previously there? It's just an association, no causality. There is a big debate, and there is no way to answer that. The only way would be a very large prospective randomized trial in patients with complete response. Some of them having surgery and some of them not. That study never going to happen anyway. So we look at, what happened when patients had a regrowth, how they compare with the patient that they have surgery up front. Doesn't seem to be any difference in survival. So whether you do the surgery up front for incomplete responders or surgery for regrowth, which to some degree they are also incomplete responders, no difference. Are they exactly the same? We don't really know, but the data suggests that it's not such a big problem. Now, when we were doing our trial, Germans published a trial very similar to ours. They did induction versus consolidation, so chemotherapy first, followed by radiation followed by chemo. In their case, they operated all the patients. Okay, the response was greater, like in our case, when you do radiation first. When we compare the result with our result, because they were very similar design of the trials, of selective watch and wait in the overall trial versus mandatory watch and wait, the results are exactly the same. DFS, local recurrence, and distant metastasis-free survival. This data is not a randomized prospective trial, but it's probably the best data that we have to suggest that watch and wait probably not penalizing the patient, because in our case, half of the patients that didn't have surgery. In the German group, all of them had surgery. Now, there is a debate. Okay, we have done watch and wait. Half of the patients do well, they don't need surgery. Now, half of the patients, they have surgery. Our global results are the same compared to historical control, but what happened with the patients now that they don't respond? So of course, they are more aggressive. the rate of local recurrence is higher and the risk of distal metastasis is higher for the patient who got surgery. But when you pull all of them to do local recurrence and distal metastasis are the same. Why? Because we are selecting biology. What we are doing with the radiation and the chemotherapy, the tumor that they go away because they have better biology than the tumor that they don't go away. So you have to expect that when you do surgery in a patient that hasn't responded to chemotherapy and radiation, you are dealing with more aggressive biology. We have seen, and I didn't show the data, that when we do coloanals today in patients that have not responded to chemotherapy and radiation, they do very poorly. Coloanals, they used to work very well when you operate the patient that they didn't need surgery. But when the patient now needs surgery, you have to watch out because the rate of recurrence and metastasis is much higher. So this has to give you an idea also for the issue of local recurrence or local excision after chemoradiation. People say, okay, well, local excision can be done as a salvage. I think in some cases you can't, but you have to be, worried that in this case, the fact that the tumor has survived is on itself a very bad prognosis, and you are more at risk of having. So I think that's something to keep in mind when we. Now, you remember we talk about complete response, incomplete response, and incomplete response. So we analyze the data by type of response at the stage. And what happened is that the organ preservation rate for patients who get a perfect response is very good. For the one that they have near complete response, half of them recover, half of them don't. And for the incomplete responder, they all have TME. Of course, nobody had, the organ preservation. But if you look at disease-free survival, the clinical response stratify very well the outcomes. The patients that do the worst are the ones that they have surgery. The patients who do the best are the ones that they have complete response, and most of them don't require surgery. The ones that are in the middle, they are not complete responders. So clinical response is a very good predictor of what's going to happen long term. And this is important because the response is what we use for escalation and de-escalation, and is something that can be used in future trials. And this is not different than when people did surgery in everyone and stratify the response based on pathology, by TRG or by the YPT. You can stratify outcomes by complete, pathological response, intermediate pathological response, and incomplete. So I think clinical response is as good as, pathological. And comparing with the German trial, we did the same thing. We compared the clinical complete responders with the good responders by pathology, same survival, near complete responders to the near complete responder by pathology, same survival, and the incomplete responders clinically and pathology is again very similar. So clinical response is as good predictor as pathological response, and it's something to keep in mind. So, the whole issue of watch and wait rests on our ability to detect residual tumor, that is going to lead to regrowth. And here we look at our own accuracy of endoscopy and MRI, and the concordance between them. Of course, we have 30% rate of regrowth, so our endoscopic and radiological tests are not 100% accurate. These just reflect the same thing, that regrowth. I think we are, the accuracy is approximately 60% from the MRI, a little bit higher for the endoscopy, makes sense, because most of the regrowths happen in the bowel wall, and you see them in the bottom. And this is the statistics. When we compare both of them in the concordant cases, the rate of accuracy goes a little bit higher, but not that much. Something that we encounter all the time. I do an endoscopy, I say this tumor is gone, and then the radiologist says it's not gone, there is some DWI, so we have this discrepancy. So we look at this. So, this tells you the cases that they were concordant and the one that they are discordant, and we look at that. So what happened when they are discordant and happen when they are concordant? So we look at these curves. You have the two tests telling you that there is a complete response. Probability of organ preservation is very, very good. The rate of regrowth is going to be lower. If one of them says a complete response and the other one is an incomplete response or a near complete response, it's going to be in the middle. If both of them say this is a near complete response, organ preservation is low. So that kind of gives you an idea. If both tests are in agreement, okay, good shape. If both of them say this is a near complete response, you have to see that patient, take the patient to the OR or see them very, very often. So that's something that we have learned from that. So these are things that we have learned from the OPRA trial. Of course, there are now new kids on the block like ctDNA. We were talking about it. We did some pilot in the patient from the OPRA trial doing a ctDNA. We use, a very sophisticated technology, Vision Signatera. This is using whole genome sequencing and with one of our Italian fellows, Paolo Manca. And we look at, the fraction of ctDNA at baseline, correlate with the size of the tumor, the one you were talking about. The bigger the tumors, the more advanced the tumor, positive lymph nodes, the higher the fraction. The fraction at baseline also correlate with response, probably with survival. And then during treatment, also the fraction of ctDNA as it decreased during treatment was predictor of response and survival. And during surveillance, also if it was negative, the probability of tumor coming back, it was very low. So this is data. It's still very preliminary. There is a lot of work going on in this field, and I think this is something that we might use in the future to select patients for watch and wait and to monitor long term. So, of course, bowel and urinary function seems to be better in patients that they have watch and wait compared to the patient that they have, TME surgery. Pretty interesting. When you look at quality of life at the end of the day, there is not a huge difference. But patient one is to be cured from the cancer. And they will accept some degree of bowel dysfunction, TME, or even an APR, as long as they are cancer-free. It's unequivocal that, the bowel and urinary and sexual function is going to be better if you avoid surgery. Maria Wilmar, one of my fellows, has looked at cost effectiveness because we say, well, we are avoiding surgery, but we are putting the patient to this follow-up, doing all these tests. Is that effective from the, society point of view? And it seems to be, as long as 20% of the patients or more are going to be in the watch and wait. So yeah, this is probably better for the patient, doesn't penalize survival, and probably is better. So what we have learned from the OPRA trial, we learned that tumors are more responsive than we originally thought. When I started here in Minneapolis, we have 18% pathological complete response. That's what sparked my interest in the topic. But we have recognized that now 50% of the rectal cancers, at least locally advanced rectal cancer, can respond. The response takes time, and that's what we have learned from the timing trial and from just including the near complete response. You need to give tumors time to respond. Tumors take time to respond. It takes time to regrow. So you have to be, and again, the TNT and the lane, seems to increase the rate of organ preservation. Clinical response is a very good indicator of biology. Non-responders at high rate of both local recurrence and distant metastasis because we select biology. And I think that more aggressive biology is something that we need to keep in mind when deciding what salvage operation this patient has. And both endoscopy and MRI are necessary and complementary for response. None of them is perfect. More regrowth involved the bowel wall. Endoscopy is the number one. And there are new methods such as ctDNA to detect minimal residual disease that probably are going to evolve in the next year. So the issue is, okay, we have done this thing. Where do we go from here? And there have been a number of things that they are doing. One of them is, okay, we are doing now watch and wait in stage 2 and stage 3 disease, and we are doing TME in early stage rectal cancer. What do we do? What treatment escalation, treatment de-escalation, better select the patients. I'm going to talk a little bit about it. One of the easiest thing, again, early rectal cancer, we are doing, watch and wait for advance, and early rectal cancer that seems to respond better. We are not doing this. Over the year, we have done a number of trials, including the C6041, also came from here, from our experience with local excision. We did that through the American College of Surgeons Oncology Group. A great response rate, much higher than what we observe in advanced tumors. At least half of the tumor go away doing the assessment right a few weeks after radiation. The timing trial, so that we went from 18 to 38. If we extrapolate, we started in the early tumor from 40, probably we'll expect maybe increase to 80%. The Star Trek trial, we did that. Just give radiation, short course and long course, and then watch the patient, 80% organ preservation. So I think probably we have to keep that in mind for early stage tumor. They were not TNT, they were just radiation. There have been attempts to accomplish the same with chemotherapy. That's something that is worth pursuing, and that's been explored. Just to talk to us, Philip, this is endocavitary radiation in addition to external beam radiation. So patient get external beam radiation, and then we get the machine, the new machine, not the old Philips 50, and just treat the area. The response rate goes up, organ preservation over 80%. So this has been resurrected, and something that we did in Minnesota in the 1970s and 80s particularly Dr. Rosfini, is now being studied all over the world. And we are getting a machine at MSK to start doing it over there now. So, we'll go back to the old things. Now, of course, there is the issue of radiation oncology. They want to give more radiation to, increase the response. I don't know if this is a good idea. I'm concerned about it. Number of trials going on about this issue. More chemotherapy based on the PRODIGE 23, adding irinotecan to FOLFOX. This is a study that will be published soon. We started this trial years ago. My colleague, now the chief of colorectal surgery at MD Anderson, Joseph Smith, is leading this alliance trial. It will be published soon. Accrual was completed a year ago. We'll see if FOLFIRINOX is better than FOLFOX. But also there is a case for de-escalation. Remember, we came to this idea just to increase the response rate. We never proved really improving in survival. Are we doing too much? Is TNT too much for these patients? And this is one of the questions that we have to ask ourselves. When we compare OPRA with the German, remember they were similar design, chemo first versus radiation first in 2 arms, in 2 studies. They did surgery in all of them. We did watch and wait. Very similar design. Some differences. We use more radiation than they did. They didn't do a boost. We use way more chemotherapy than they did. They use some oxaliplatin as a sensitizer during the radiation, but they use only 6 weeks of FOLFOX. We use 16 weeks of FOLFOX. And the results were exactly the same. So do we need to give that much radiation and we need to do much chemo? In the IDEA trials for colon cancer, we went from 6 to 3 months. And in rectal, we are giving them 4 months after having given them chemotherapy during the radiation. So I think there is a huge opportunity for de-escalation here. We will need to fight medical oncology and radiation oncology, but I think this is a fight worth fighting. Going back more to the idea of the time of the treatment and to the escalating, more treatment. Predictors of response. We have done a lot of work. That work also started here when I was at the Masonic Cancer Center. The first paper was here with Megan Rothenberger, the Rothenberger daughter, and other people that we started looking at predictors. I'm still looking at predictors. We pursue the idea of KRAS and APC, and the APC mutation seems to be a predictor of good response, the KRAS mutation of bad response, and that seems to be independent, and they are more important than the T stage and the N stage when you look at these predicted markers. Just combining those 2 mutations, if they have none of those markers, the response and the survival is very good. If they have both of them, the response is very bad. So this is work in progress. This is already in 374 patients treated with TNT. At the beginning, the markers were difficult because different treatment schedules, different patient selection, different endpoint. Now that we have many more patients with uniform treatment and good endpoints, we're starting to see some markers that might predict response. We have also looked at transcriptomic. We have done RNA, and we have found, some markers such as, the IGFR. It's a bad marker. It was identified in TCGA, and I think we have an opportunity there because, these are of the PA3 kinase pathway that now might be targeted with something as simple as aspirin. Other markers, this is work that is pursued by Karuna Ganesh in our institution. L1CAM seems to be also a factor that might predict response. We have looked at the immune microenvironment. We have identified a subgroup of tumor that seems to be, these are all MSS, that seems to be immune hot, that had a better response as good as the MSI tumors. And now we can identify these tumors just doing immunohistochemistry in the biopsy. And we have been able to show that the immune hot, that they have the same expression of CD8 and PD1 that the MSI tumor, they have a much better response and survival. So I think we are advancing a little bit in finding predictors of response to chemoradiation. But again, we have done all this work without taking into consideration the MSI status of the tumor. The trial was started, the OPRA trial, before we knew the status of the tumor. MSI is very uncommon in rectal cancer, 3%, 4%. But this study from our group showed that immune checkpoint inhibition for MSI was 100% effective. All the tumor went away, and none of them required radiation chemo surgery. And this still holds now over 50 or 60 patients. I don't know how many we have now in our institution. In rectal cancer, MSI, with just single agent anti-PD1, thoroughly bad. And there is now a study, international study, to try to validate the results. Called the AZUR-1 trial that is being done in other countries, and I think they are moving extremely fast. So we will be able to show this data from MSK validates internationally. But the whole interest in immune checkpoint blockade is just adding a new dimension to the whole idea of improving response. Can we use immune checkpoint inhibition in MMR proficient rectal cancer? And here there have been two approaches. One is, okay, we're going to use TNT, and then we're going to give immune checkpoint inhibition in addition to TNT, or in addition to chemo, or in addition to radiation. The alternative approach has been, can we use TNT as an alternative approach to, immune checkpoint blockade as an alternative to TNT. I'm going to talk a little bit about that. So immune checkpoint blockade in addition to radiation or chemo. Why do that? Because radiation, hypothetically works through some immune modulation of the tumor microenvironment, and immunotherapy might increase the response just by acting through this immunomodulated mechanism. So radiation seeks to promote the release of antigens, promote dendritic cell activation, and recruitment of T cells to the tumor microenvironment. So, that's the rationale for combining immune checkpoint inhibition with radiation. There have been a lot of trials. This is probably the hottest topic today. This year in ASCO, which was this weekend, there were probably 10 or 15 abstracts about different combination of immune checkpoint blockade with radiation or with chemo. This is a recent kind of pool analysis. The problem is that they use different agents. Sometimes they have anti-PD-1, sometimes anti-PD-1, anti-CTLA-4 against radiation, short course, long course, chemotherapy, no chemotherapy. It's very difficult to make sense of this literature at this moment. It's debatable that they really increase the response rate that much. They have used PCR, CCR, but it's debatable at this point. It seems to be a trend towards it. For PCR, for CCR, again, the same. What seems to be clear, which is very interesting, is that maybe short-course radiation has more immunosensitizing effect than long-course radiation. Again, this is all preliminary data, phase 2 trials, pretty variable designs. I think we're going to need to have a long time, because now I think there seems to be more studies than patients to put in trial. This is a kind of a little bit of a mess. We need time to see where this thing is going to settle. But there is the other approach of using immune checkpoint blockade as the only treatment for MMR proficient rectal cancer. In the metastatic setting, immune checkpoint blockade for MMR proficient rectal cancer essentially doesn't work. And I had a lot of debate about this area with our medical college, and we have shown some tumor immune hot. This paper by Miriam Chalabi from Amsterdam show for the first time that in colon cancer patients, just a couple of shots of immune checkpoint inhibition could achieve complete response in approximately 27% of the patients. That corresponded to our immune hot tumor in our transcriptomic analysis. So we hypothesized that this could work. And we, in fact, went as far as designing a trial, selecting patients for immune checkpoint blockade based on the baseline transcriptomic and expression of CD8 and PD-1. But I think what happened, something that changed the game, is that these new agents, botensilimab and balstilimab, I have difficulty pronouncing the name. One of them is an FC-enhanced anti-CTLA-4, which acts through a different mechanism, and they seems to be more effective than just the conventional anti-CTLA-4. So in our institution, the medical oncology, they say, okay, we're not going to do just immune checkpoint blockade for MMR proficient based on the immune profile. We're going to give it to all of them. And we have designed this trial that I'm not necessarily convinced that it's the best design, but this is what we are doing now. We are doing for tumors that they are in the lower rectum and they are MMR proficient, upfront treatment for 6 months with this combination of anti-CTLA-4 and PD-1. The study is still ongoing. I have seen some complete responders. I have seen many non-complete responders. So we'll see if that group that will hypothesize that will respond to immune checkpoint inhibition based on the immune profile of the tumor, it will thin out or not. But I think it's exciting to see what is going to happen. So that brings us to the last part of my talk. This is a food for thought more than anything else. So when you look at the molecular profile of the tumor, rectal cancer is very heterogeneous, different mutation, different combination, but this is just a representation of the most important genomic alteration. Of course, the best one is the MSI. MSI, we know now the immune checkpoint inhibition, 100% response in rectal cancer. But there are other mutations such as HER2 that can be targeted. And, The Mountaineer trial showed that anti-HER2 was effective in the metastatic setting. So we have a trial now of HER2 positive tumor rectal cancer, treated them initially with a combination of tucatinib and trastuzumab, which is an anti-HER2, to see if that will, promote complete response. Again, this is a proof of concept, but this is something that is going on in our institution. But now we have other mutations for what we have targets that they are in the metastatic setting. Are we going to move that to the neoadjuvant setting? Who knows? Maybe we have encorafenib for the RAF 600B. We have now the PA3 kinase. I was talking about those IGFR, enhanced tumor that we identified as a bad prognostic. Maybe we can have that. It might increase the response. And now there are also a lot of interest of specific mutations in the KRAS that they are being treated, in the metastatic setting, but we can foresee that in the future that it might move to the neoadjuvant setting. So, things are moving really, really fast. I think the idea of achieving organ preservation has sparked a lot of interest in moving these agents to the neoadjuvant setting, even though maybe we might not see much improvement in survival, but complete response might be a point, an income that is worth enough pursuing. So I'm going to leave it there. It was kind of a fast overview of what is happening in the field. I think the treatment of rectal cancer has changed a lot since I was here. And again, many of these ideas, at least from what is concerned to me, came from my days here. I think we have made a lot of advances in organ preservation, eliminating potential toxicity. I think we have work to do. I think we have exciting data on treatment escalation, but also I think we have the responsibility of de-escalate the treatment and not be completely sold on the idea of TNT for everyone. I think we have to also take into consideration the importance of the response and how we can use the response to de-escalate, assessing, the response in the middle of the treatment. And I think we have to have open mind to new things that they might come from the better understanding of the biology of the tumor. So again, this is the work of a lot of people, and now from my institution, again, my colleagues, people from medical oncology, radiation oncology, it requires a lot of people to do this type of work, fellows, that they are now some of the attendings, even chiefs in other services, and also the Rectal Cancer Consortium. The clinical trial that I have done in my career were done thanks to the generosity and the ingenuity of a lot of colleagues from the American Society of Colon and Rectal Surgeons, that they believe in the ideas that we presented to them, and they were willing to put their patients in these trials, and of course to the patients that they agreed to include in some of these the studies that at the time were considered a little bit out of the mainstream. So thank you very much. It's a pleasure to be here today with all of you. Thank you.
That was an unbelievable summary of 26 plus years of work in 30 minutes. So thank you for that. Questions for Dr. Garcia-Aguilar?
I don't work in this space. As a medical student, I had a chance to work with Professor Sir Alistair Currie and Dr. Wiley, who discovered apoptosis. I think about cell cycle and maybe the traditional types of chemotherapy that seem to work on a cell cycle basis. You had to be in a certain period of the cycle to get full effect of the chemo. Has there been, I'd asked GPT 5.2, but now you're here, I could just ask you, has there been any work with trying to get all the cells to cycle at the same time using colchicine, methotrexate, feeding or fasting, either in a cell culture or in a mouse, try to get all the cells at the same time and then hit your chemo right at the right time?
Not to my knowledge at the clinical level. I think the closest that we have come to that was the idea of the chronobiology. Just doing chemotherapy at some time of the day, because it was supposed to be some, relationship of the cell cycle with the time of the day. But I think that's probably the factor that we have gone with that. I think the idea of, for example, colchicine, we haven't explored, and that might be interesting to sync all these cancer cells in the same way. No, that's an interesting idea. I will look into that. See,
Pulse, maybe even pulse radiation.
Yeah. Well, the issue of the time of the radiation, yes, that has been correct. For practical purposes, now we use, either for the short course or long course, we use only one time of the day. But we are re-irradiating patients. we are using different fractionation and sometimes twice a day. So I think the timing has been both in chemotherapy and in radiation therapy. It has been the area they have more interest, but I haven't looked at other markers. It might have been some work, definitely at the experimental level, but I don't know at the clinical level. Clinical level has been chrono, chemotherapy, and chrono radiation.
That was so good. It was overwhelming. I feel like I have to come back and do another fellowship with you. I have two questions. The first one is, you showed your first patient, that had a regrowth, and you did a biopsy. And so I was wondering, what's the value of a biopsy when you see a regrowth? And then the second question I have is more from a research standpoint. You showed your transcriptomic work, and you find an immune hot kind of a profile. Do those findings that you had correspond to the more established consensus molecular subtypes that we have, or your work is completely different and we should find different ways to categorize colon cancer?
Yeah, those are two good questions. The reason why I biopsy the regrowths is to convince the patient that they have surgery. Say, listen, this is not surgery that is saying there is cancer there, you need to have surgery. I mean, in that particular case, it shows that maybe that patient you might have done local excision. The problem is that it's too difficult to see how much tumor is there, what is tumor, what is not. And if there is tumor superficially that you prove with an endoscopy, you have to assume, we look at that years ago, and where the cancer cells are after radiation and chemotherapy when you do TME, and it's unpredictable to see which layer they're going to be. So the main reason, the answer to your question, is just to show the patient, you have cancer. I think you should have surgery. We have tried watch and wait, didn't work, forget it. And then we will have another talk about whether we should do localization or not. Now, the second one, we look at that. We have done also the CMS classification. But the same classification don't correspond exactly the same. As you noticed when we did this analysis, it was, with the transcriptomic data, we restricted the analysis to their signature, their immune signature, and we separated the MSI tumors. So we have 3 groups in the MSS tumor. They don't correspond exactly to the CMS classification. In fact, most of the tumors that they are immune hot in the CMS they correspond to CMS4, which is the more aggressive one. So it's not a complete overlap, but the CMS4 is much wider in more cases than the small proportion of immune hot. So they are probably not exactly the same. We haven't done enough work in that area, but they are not exactly the same. So I think we might need to look at them with a grain of salt. The problem is that we couldn't use the transcriptomic because you need a lab that is CLA approved to use that as a marker. So that's the reason why we went from transcriptomic to immunohistochemistry, because immunohistochemistry you can do very easily. You get a biopsy, do PD-1, CD8, and you say, well, this is immune hot, I can do whatever, design that for a trial. But it's an area that we should do more work. The problem is, again, is you need a lot of patients, you need a fair amount of work, and it's just something that progresses slowly. But it's a good question. Yeah.
So my first case in fellowship, July 3rd, 2001, was an exent with you. And it was, at that time, we did a lot of pelvic exenterations for patients who had been undertreated surgically for local excision. And then I think there's data that suggests that patients who are in watch and wait, like I think the Watch U data is that maybe there's a 40% compliance with all of the studies. So I get that patients who are very good about compliance show up, but the majority of patients do not show up for all their visits. So I'm just sort of trying to put this in place with who do you not choose watch and wait for in terms of like age of the patient, height of the tumor from the verge, who gets chemo only and goes on to surgery?
Yeah, that's a good question. I mean, again, we need to have many hours to talk about the horizontal rectal cancer. You are correct. Watch and wait requires compliance. I mean, if you see a patient that is not going to be compliant, you better take the rectal out because, it can be a disaster. I mean, regrowth occurs slowly, but with time, if the patient doesn't show up for 1 year, it's going to be a problem. So I think that's critical. You have to just judge the patient and make sure that they cannot sign that compromise. The main distance in the upper trial from the anal verge was 4 centimeters. These are low tumors. I mean, watch and wait makes sense for tumor that they will require. The definition was tumor that will require a hollow anal or an apical. Those are the ones that benefit. Is organ preservation the only endpoint? Is no. Okay. Now we know that with chemotherapy alone, you can achieve a number of clinical complete response. I have patients who doesn't work with chemo alone. But for example, a young patient, I had a case of a patient that died many years ago. Very distal rectal tumor that I can do staple anastomosis, very well staple anastomosis. And he was like 21, and he has a rectal tumor that he has a possible ignorance. That patient I probably would give chemotherapy and they will see the response. It's better for that patient probably to avoid the radiation therapy, preserve fertility, probably sexual life, and just get the bowel dysfunction that is not that bad when you avoid radiation, than put into treatment. So I think all requires common sense and requires kind of an open mind and an adaptive approach. I didn't show some slides that I presented the other day. Just out of curiosity, we do endoscopies between the radiation and the chemo, between the chemo and the radiation. And of course, when you have done many cases, when I look in the middle of the treatment in patients with TNT, I can predict in most of them what is going to happen. So this tumor is going to respond, this tumor is going to respond. So I got like 94 cases, half of them responded, half of them not responded. I gave it to the fellows and my attendees. I said, just looking at that in the middle of TNT, are we going to predict response? 86% accuracy. So, the point is that, you start the treatment, but you can, in your mind, you don't have to be committed to the whole thing. You see that the tumor responds very well, and you have other options, I'm going to stop, or I'm going to do surgery, or I'm going to do even some watch and wait. So I think there is a lot that we need to learn, and the idea of TNT shouldn't be sold as a package necessarily in every patient. In addition to probably shorten down the chemotherapy, which I think I wouldn't go beyond 3 months, I think we have to be adaptive. And I think the challenge is designing trials with that approach. It's very difficult. We have been struggling with that idea. But I think there is room for that. And I think you have to select patient. Definitely, upper rectal cancer, particularly in a female, I wouldn't do the radiation therapy first. I do chemo. I tell people, yeah, radiation therapy is a little bit better in terms of organ preservation, but chemo upfront is still okay. And you can still do radiation or go to surgery. So which was the design of the prospect trial. So we use a lot of prospect.
That's such an interesting topic for T3N0s.
Yeah.
And for mucinous tumors that tend to be less chemo or radiation sensitive.
Yeah, and we are working with the Dutch, which still they are very interested in avoiding TNT. I mean, the Europeans, even though they are the one who did the big trials on TNT, they blame us for being the one who pushed TNT. I say, forget it. We are not. We are trying to design a trial for intermediate risk mid and upper rectal cancer surgery up front. You can do treating as a colon cancer, do surgery, and then if the legals are positive, you give them chemo. The tumor is away from the circumferential resection margin. They have no MBI. Even with few potential lymph nodes on MRI, you can do surgery and probably they will be fine. So I think we're gonna, in the next few years, we're gonna move the pendulum. I hope we're gonna be able to de-escalate a little bit the treatment and just pepper our enthusiasm with just one approach for everyone.
Miles, any final comments? Thank you again.
Okay.